is a great pleasure and honor to introduce this year's Israel Society of Cardiothoracic Surgery's guest speaker, Dr. Craig Smith. Dr. Craig Smith is currently the chairman of the Department of Surgery at Columbia Presbyterian Hospital in New York City. He formerly was the division chief of cardiothoracic surgery at that same institution up until 2009, and he served as the 92nd president of the American Association of Thoracic Surgeons Society. Craig Smith has distinguished himself as a unique and gifted surgeon and individual. Amongst his many scientific and surgical achievements are his launching and leading Columbia's transplant program to the largest in the United States, not to mention that the department is one of the leading departments of cardiothoracic surgery. He has authored 176 publications and most recently has served as the principal surgical investigator for the famous PARTNER study that evaluated the sapien valve. Craig's uniqueness extends way beyond the limits of the OR or the research lab. He is a true leader, a revered teacher and mentor to his staff, a tireless, devoted, and compassionate doctor to his patients. He commands the respect of our entire community as well as the cardiologists, and is a role model to, I think, the developing concept of what a heart team should be. To sum up these very special qualities, let me quote what President Clinton, who was operated on by Craig Smith and had his CABG performed in 2004, so succinctly put it when in 2007 he awarded him the American Heart Association's New York Heart Association Award by saying Craig Smith is a good man. Today, Dr. Smith will speak on the impact of randomized controlled trials and appropriateness criteria on CABG versus PCI. Craig, thank you very much for accepting our invitation. It is a true privilege to have you with us, and we look forward to a great day.
Thank you for that exceedingly generous introduction. I will do my best to live up to my part of the bargain. I am greatly enjoying my first visit to Israel. I've been very graciously hosted every step of the way. These are my disclosures, by the way. And I was once, when speaking about TAVI, accused of being an interventionalist by a member of the audience. I guess I should also mention my hosts have pointed out to me at dinner last night or the night before that a proper Israeli always answers a question with a question. So I guess I should be saying, why are you asking me this question? I'm just a surgeon. But I will do my best to get through it. This will be in essentially two parts. First part, we'll look at how results of PCI and CABG compare with respect to benefits, risks, patient factors, and so forth. In the second part, we'll talk about how PCI and CABG are being used. And that involves adherence to guidelines, overuse and underuse, essentially. The data for the first part is answered mostly by randomized trials. The data for the second part is answered by appropriateness studies. So to address the first part, we'll go way back to the beginning of coronary bypass. I'll just point out that looking at these 7 randomized trials, 2 and beyond 10 years, CABG shows significant benefit compared to medical treatment. And what did we learn from that group? That the ones who do best have complex disease, 3 vessels, left main, symptoms, reduced ejection fraction. What do we also learn then is that the ones who do better or as well with medical treatment have less complex disease and normal ejection fraction. I'll just mention that you probably will find we haven't learned all that much other than this in the interim. We also know, going way back, that CABG, now comparing it to PCI, is more superior the more complex the disease, the more vessels that are involved, as you can see on the left. And we know in this meta-analysis that the longer you follow patients comparing CABG to PCI, the greater the benefit is. This study out to 8 years. Another, again, review, looking back at a non-selected large population study from New York State, this using bare metal stents. You can see a dramatic difference in the frequency of revascularization in the CABG group, or in the PCI group rather, compared to CABG. with a difference as well in survival at 3 years. Now, the obvious criticism of this has always been, well, that's bare metal stents, it's old data. Well, this was updated not too long ago in the New England Journal. This is just to make the point, these are very different patient populations, completely unselected. CABG patients were older, lower ejection fractions, more frequent MIs, and a variety of other comorbidities that would not surprise you. And the curves still look somewhat reminiscent of the curves with bare metal stents, a much higher frequency of revascularization using drug-eluting stents. And if you look at the survival curves, both for 3-vessel and 2-vessel disease, there's a significant difference appearing at 18 months. And you can speculate, comparing the curve on the left from the 2005 bare metal data to the 2008 drug-eluting data, that's only out to 18 months. You have to ask the question, will those curves continue to diverge as they appear to be doing? And the editorial comment on this paper from Dr. Carrozza was that CABG remains the standard of care for multi-vessel disease. So that's where we were a while ago. Now, what about some patient factors? Diabetes, the obvious one. The ARTS trial, although it showed no significant differences at 3 years in general, there was a striking benefit in CABG against PCI in the diabetics. Same true in the Berry trial, very familiar to all of you. 10-year survival, CABG superior to PCI in diabetics. So around this time when I would debate this topic, the answer always was, well, that's bare metal stents, it's old, bad medical treatment, wait for the Freedom trial. So that's what we've been doing. I should also mention, I guess, this meta-analysis of 10 trials across the top, simply showing most of the benefit leans to the left of the line on the CABG side, and again, diabetics do much better with CABG. So that is where we stood until the Freedom trial. The Freedom trial is the largest randomized trial of PCI versus CABG ever done in diabetics, and it incorporated very good stent therapy and very good medical treatment, a 1-to-1 randomization, a superiority trial over 7 years, 1,900 patients at 131 centers. The primary outcome was all-cause mortality, non-fatal MI, and non-fatal stroke, and some secondary outcomes. Inclusion criteria included diabetes, greater than 70% stenosis, and symptoms or evidence of ischemia. Important exclusions rather, were left main stenosis or more than 2 CTOs and acute STEMI. All angiograms were reviewed by an interventionalist. This group knows better than I what the diabetic treatment consisted of, but it was aggressive. The surgical treatment favored IMA in all cases whenever possible, and on-pump versus off-pump was left to our discretion. The pre-stent treatment by the interventionalists, I won't dwell on. I think you all are familiar with that. 1,400 patients consented on the left, 1,900 on the right, 953 randomized to PCI, 947 to CABG. Euro scores, average sort of spread. Syntax scores clustering towards an average in the high 20s, so relatively complex disease. Compared to similar trials, Berry, Cardia, and so forth, you'll notice that Freedom and Syntax, which I'll talk about in a moment, had a predominance of 3-vessel disease compared to the other trials, so probably a good sample. We'll skip that. The primary outcome of death, stroke, or MI, a very significant difference, benefiting CABG. So consistent with previous studies. Myocardial infarction, same thing. All-cause mortality, same thing. Stroke, of course, goes the other way, as it does with surgical treatment. So stroke was worse in the CABG group, about a doubling compared to PCI. Incorporating stroke into a combined endpoint makes the difference a little less dramatic, but it's still there. And then, of course, a lot of this is driven by a high frequency repeat revascularization in the PCI group. No major subgroup differences, leading to a conclusion that I'm sure you've all read, is that CABG surgery is the preferred method of revascularization for patients with diabetes and multi-vessel disease. An interesting study that you may or may not have read that looked at the cost benefits in the Freedom trial. You'll notice that the initial event is more expensive for CABG on the left. That's not surprising. But as time goes on, the frequency of repeat PCI, coronary bypass procedures, and hospitalizations adds up to bring the two curves together so that by year 5, the curves are converged. And putting this into a proper quality of life analysis, you can see that the red dot lies in the upper right quadrant where increased quality of life is achieved at a higher cost. But if you look at this according to syntax scores, low, middle, and high on the right, you can see that the red dot is moving down towards the sweet spot in the right lower quadrant where higher quality is achieved at lower cost. And that was the conclusion of the authors in essence. So it was not really surprising to have this headline in JAMA following the release of the partner trial. Now what about syntax, the other major randomized trial that's come out recently? 1,800 patients randomized. I know you're all largely familiar with these findings, so I'll go pretty fast. 62 sites in Europe, 23 in the US. This was a largely real-world population, mostly 3-vessel and left main disease. There was both a registry and a randomized cohort, and I'll talk later about the registry. No major differences in patient characteristics at the beginning of the trial. This is the 1-year results, and as I think most of you know, again, stroke went against in the upper right. Stroke went against CABG by more than 2-fold, almost 3-fold. Death, CV, and MI as a combined endpoint about the same, but repeat revascularization greatly different, driving the overall endpoint, the MACE, to be highly significantly better with CABG. Now at 5 years, this was recently published, by 5 years the all-cause death is trending in favor of CABG, although it hasn't reached significance. Cardiac death, highly significant difference favoring CABG. Myocardial infarction, same thing. CVA, again the difference that we saw initially, not much difference at 5 years. Adding that to the endpoint, again pulls the difference down a little bit, doesn't eliminate it, still significant, and driven to a large extent by repeat revascularization that continues to diverge at 5 years, driving the MACE endpoint, which looks very similar. Now, if you look at the relationship of these results, the MACE in particular in this case, to the syntax score, at the low syntax score, no meaningful difference. Looking at 3-vessel disease in the low score group, it's approaching significance. But then as soon as you get into the moderate intermediate scores, here for all comers and then here for 3-vessel disease, you can see it's significant, and it only gets more significant as you go into the higher scores, here for all comers, here for 3-vessel disease, and then in left main for the high scores, an even more striking difference. So a clear correlation with syntax score and the benefit. So to summarize those findings, this would suggest that 71% of the patients in this kind of a population are best treated with CABG. The remainder, the 22 plus 7%, 29%, are very well treated with PCI, but it's not the majority. And you've seen this group. Now, what about real-world experience? Here's where I'll touch a little bit on the registry. There were 3,000 patients in syntax, 6% in the PCI registry, most because they were too high risk for CABG. 35% were in the CABG registry, mostly because they had complex anatomy. So what did those results look like? Well, here's the 5-year CABG registry. So just fix this image, and then here's the PCI registry. So in the registry, same general trends favoring CABG. So what I'm frequently told when I'm doing this in sort of a debate setting is, why worry about restenosis and revascularization? You can just do PCI again, and you can see from the New York State data that's very often what's done is to repeat PCI. Well, is that so benign? In this experience, 36% of the patients coming back with restenosis presented with STEMI, non-STEMI, or unstable angina. In this experience, somewhat similar from Canada, 70% of the patients presented with STEMI or NSTEMI, an unstable angina, so it's roughly similar. How about the effectiveness of treatment? Well, in this relatively small group, 24 patients who had re-restenosis treated with PCI, the re-restenosis rate was 23%, only 23% according to the authors. Here's another experience with 201 lesions with re-restenosis. Treatment of restenosis, I should say, and the restenosis rate, 26%, 26% with different types of DES. Another experience at 12 months treating restenosis. I'll just point out at the bottom, I want to ask you to read the slide. 7% mortality, 28% target lesion revascularization, and a 43% MACE rate. So I would say not benign. Again, restenosis, 8% mortality, 44% MACE. This is a more recent experience. Focus on the pie chart, not the bars at the left. In the patients with the simplest restenosis, which is the focal group, 29% recurrence after treatment. In the more diffuse group and the occlusive group, even worse. So treatment of restenosis, not so simple. And does it have an impact on survival? This is relatively old data, but shows the difference between patients with no restenosis, patients with a non-occlusive restenosis, and those with an occlusive restenosis, with a significant difference in mortality. So I would argue that restenosis, repeat revascularization, is not completely benign. Now, part 2, assessing how we use CABG and PCI involves appropriateness, which is defined as it is here. Health benefits exceed the risks by a sufficiently wide margin that the procedure is considered worth doing. There are 2 areas of this that are most emphasized. Overuse, that's patients who received treatment that was graded inappropriate, and underuse, which refers to patients who did not receive a treatment that was graded appropriate. I'll show you some examples of those as we go along. Now, how is this established? There's a literature review and an expert panel. The results of that are tested against real patients using the criteria developed from that above by reviewing medical records, and an expert panel scores each record. Some of the important variations on this approach: there is one school of thought that you should only use published evidence. The other more common school of thought is that you should incorporate expert opinion. This goes back to the RAND UCLA methodology. And then another debate is whether or not experienced practitioners who aren't part of your panel should be part of the study. This is the most recent update. This is, again, I didn't use the European guidelines because I'm not part of them, but they are not that dissimilar. This is the American College of Cardiology, AHA guidelines from their most recent update on revascularization. These 6 categories received the most attention to revision, and they're summarized here. Come across, yeah, green, okay. You can see in the CABG column, these are all considered appropriate. In the PCI column, there are now 3 uncertain indications for 3VD with a high syntax score, isolated left main, and left main with a low syntax score, and left main with a high syntax score is considered inappropriate. So how would we look at overuse in a real example here? Here's a study done back in the 90s. 3 panels looking at these cases separately and looking for agreement on overuse. So these are patients who had coronary revascularization recommended on the basis of angiography. And how well did they correlate? There was a 2-fold variation, if you can see in the middle row, the circles in the middle, 2-fold variation in the inappropriate classification. If you look at the 3-way kappa statistic, it was 0.52 for overuse of coronary revascularization in this case. And that's not very good. In fact, in clinical medicine, how does it compare to some other things? I've listed others under that, which range from being 0.5 for hysterectomy, 0.53 for coronary angiography predicting significant stenosis, and some others, including all the way down to 0.3 for meta-analyses and their ability to predict subsequent randomized trial results. So not bad, but not good either. How about underuse? Looking at the same study. So here we're looking at patients who had angiography and had treatment recommended. And here there was far less variation between panels. So underuse, far less of an issue in this case. Here's an experience from Sweden. This is back a while now using prior criteria. And if you look at the CABG versus PCCA columns in the inappropriate, you'll see a striking difference with 38% inappropriate in the PCCA. A similar difference in the opposite direction in the appropriate column to the far left. If you look at what was happening in that group, the PTCA group was notable for having a large number of asymptomatic patients. A little bit more recently, this study compared in a Dutch cohort Dutch criteria to multinational criteria, which I believe were the European criteria. And if you go to the inappropriate column, the first on the left, you see a much higher frequency of inappropriate in the Dutch compared to the multinational assessment. The same was true for recent MI. Previous was chronic angina. So a similar difference. And what was going on here? Well, the Dutch criteria were much older, didn't take into account lesion morphology or medical treatment to the same extent. So when these were adjusted to take into account lesion morphology and the intensity of medical treatment, although it has no impact on the cabbage numbers to speak of, only makes them slightly better, it does correct quite a bit of the imbalance between the two assessments in PCI. So it does have something to do with the recency and relevance of the criteria being applied. Now, a very important question about these criteria is addressed in the next few slides, and that is, in patients who have underuse, is there a consequence? So if medical treatment is used when something more aggressive, PCI or surgery, is indicated, is there a consequence? So in this group of patients, I'll remind you that underuse here is patients who did not receive a treatment that was graded appropriate. You can see that that's the group in the PCI group, 34% of them, in the surgery group, 26% of them. And if you look at the curves, you see that when medical treatment was what was chosen, although cabbage was considered appropriate, a much higher probability of death or MI compared to the bottom line when cabbage was given when appropriate. Now, if you look at mortality as an endpoint, well, it was the same as the previous death or non-fatal MI. Cabbage stands out as significantly better than medical treatment, the higher the appropriate. So the more appropriate the indication, the better cabbage looks against medical treatment. This was not true for PCI. I didn't show you the curve, but if you look at angina, the same is true of PCI. So both PCI and cabbage look better against medical treatment, the higher the indication as by appropriateness. And just a reminder of what we were talking about from the US ACC AHA guidelines and the most relevant categories. Now, I said I would say something about the expert opinion versus using experienced practitioners issue. This study from last year, a couple of years ago, looks at this. They had a technical panel of 17 members that rated all 174 scenarios and compared the results of that panel to a physician group, 85 physicians from 10 institutions. They were blinded to the technical panel's results. They reviewed a third of the scenarios just to reduce the workload primarily to the most relevant third. And on these charts, these next three slides, the red X is the score from the technical panel. The yellow circle is the score from the physician group. So when the red X and the yellow circle overlap, it means the physicians did agree completely with the technical panel. So in the appropriate group, concordance was 94%, so they all agreed very well. Uncertain, it starts to spread out a bit. And if you look at inappropriate, you can see it spread out even more. So in fact, the concordance was down to 70%. And the weighted kappa ranged tremendously among individuals from 0.05 to 0.76. The mean weighted kappa was 0.52. More than a quarter of the MDs differed from the whole in 2 out of 3 scenarios. Some of the MDs never agreed with the technical panel, and none of them ever achieved more than 80% agreement with the technical panel. So there's really quite a bit of divergence when it comes to the inappropriate group. Now, in New York State, this has been looked at as well. There was an 18-month period when New York State looked at all the cases applying the 2009 appropriate use criteria. In this example, out of 81,000 PCI and 14,000 cabbage patients, PCI was inappropriate 14.3% of the time versus 1.1% of the time for cabbage. Now, looking beyond that a little bit, the cabbage patients in the inappropriate category, what were the scenarios? They were mostly not very symptomatic, not very good medical treatment, not very impressive stress tests. Same was true of all 3 categories of those in the PCI group. But the thing the authors emphasized was that if you looked at the cases for which there was no rating that could be done, and there were quite a few of them, there were 9,000 of those in the PCI group, and focus on this subset. This is scenario 18. Now, 2,800 of these were present in the PCI group, only 64 in the cabbage group. Scenario 18 couldn't be ranked because ACC did not think it should be rated, because it considered the likelihood so low that would ever be treated that they didn't rate it. So, and you can see why. I mean, they have no proximal left main, or no proximal LAD, no non-invasive testing, asymptomatic patients. They weren't rated. If you added these to the inappropriate cases, the inappropriate rate goes up to 23%. Looking across hospitals, there was quite a range of rates across hospitals, and this finding in general was sort of a tail in inappropriateness frequency is not unique to New York. Looking at 500,000 patients from the NCDR registry, which is a national registry, same tail on the curve for hospital frequency of inappropriate procedures. If you look at the relationship between volume and appropriateness, which is shown here, there's a very weak correlation, so oddly enough, volume does not appear to account for this frequency of inappropriate treatment. Now here's an interesting study from Ontario, 1,600 patients. On the right, those who were appropriate, and then uncertain and inappropriate to the left. You can see that 61% were appropriately treated, revascularized, 19% were inappropriately revascularized. The next several slides break this down by the proportion of patients treated in each category. So the bars look different, don't be confused by that. You look at appropriate, for example, on the right, start to add up the totals of cabbage and PCI. So all those who were revascularized, 14% were inappropriate. I remind you that the definition of overuse is patients who received treatment that was graded inappropriate. So where do we look for that? It's that 14%. So combining all those who were revascularized, 14% were done inappropriately. Looking at it a little bit differently, if you just look at the right at the appropriate bars, you can see that 69% received PCI or cabbage and 31% received medical treatment. I remind you that the underuse definition is patients who did not receive treatment that was considered appropriate. So that's the 31%. So about twice the frequency of inappropriate treatment. Now looking at the frequency of treatments within the revascularized group, you can see that the predominance of inappropriate and uncertain treatment was PCI, 82 and 86%. If you look within the PCI
we're running
group,
a little bit over the time, so I hope that's not too long.
In fact, okay, I can be done very quickly. Yeah, I think this is the last meaningful slide. Yeah, so the vascularization, the hazard ratio for cabbage compared to medical therapy was significant at 0.006, but not for PCI. And I'll stop there. So how do these results compare? I would just remind you of this slide. I know that the counterpoint to this is always that you're using old data, old drug-eluting stents, and so forth. True. I mean, stents are like buses. There's always another one coming along, and I'm sure that there will be something coming, but that's not what we have in front of us. This audience doesn't need to be reminded that a large part of the problem is medical treatment, which is chipping away at the effectiveness of both things we do, PCI and cabbage. In terms of appropriate use, I'll emphasize only the bottom 3 points. Underuse is more common than overuse. The overuse of PCI continues to be much greater than the overuse of cabbage, but that's an artifact to some extent of where PCI sits in the referral pattern in most situations. And a lot of that will be balanced by a heart team approach, and the frequency of overuse will balance. But it's still important to point out that underuse is much more common than overuse, and I'll stop there.
Thank you. Thank you, Dr. Smith.